Well, the therapeutic landscape has clearly changed, as her case definitively shows. In the past, until about 2003, 2004, 2005, she would have been treated with standard chemotherapy, but really in the last 7, 8, 9 years, we've recognized the importance, the critical benefits of frontline EGFR TKIs compared to standard cytotoxic therapy in individuals like Ingrid. There are now 8 separate clinical trials, 4 looking at gefitinib, 2 at erlotinib, and 2 at afatinib, which she is on, that have shown clear, consistent results, a major improvement in response rate, a statistically significant and clinically meaningful improvement in progression-free survival, and intriguingly, in the case of Exon 19 at least, a survival benefit specifically for afatinib compared to standard chemotherapy. Both LUX-Lung-3, which compared afatinib to pemetrexed and platinum global trial, and then LUX-Lung-6, which compared afatinib to a gemcitabine platinum combination in China, showed virtually identical results. The same improvement in response rate in PFS, but in those with driver mutation, Exon 19, about a 10 to 12 month absolute improvement in median survival compared to chemotherapy. So if Ingrid were to present to my clinic with a similar set of complaints, similar scans, similar results in her biopsy, I would have chosen exactly the same therapy. I would have chosen afatinib. Now, in truth, we have not compared afatinib head-to-head to either erlotinib or gefitinib in the frontline mutation-positive setting. Those studies have actually been completed. We're awaiting the results, but we have not yet seen the data. So it may be that they're all equivalent, but we don't know that for a fact. At least in post hoc retrospective analyses of the trials looking at TKIs versus chemo, it's only afatinib that has ever demonstrated a survival benefit. There was a time when a patient who was looking forward to a vacation in Tuscany a year hence would have been an unrealistic expectation. Certainly in 1985 or 1990, I would have encouraged that individual to move up the vacation. Now it's actually quite realistic. She can look forward, hopefully, to vacations next year and potentially 2, 3, 4 years out. There's no guarantee. There's certainly an attrition rate. These patients, unfortunately, can develop resistance and eventually refractory disease, and there is a drop-off in survival. But on average, individuals with actionable EGFR mutations will live 2 to 3 times longer than the average unselected non-small cell patient.